Hi, my name is Reagan Miller. I'm from the Respiratory Therapy Department, and I'm going to be presenting a case on a cardiac arrest respiratory failure patient. Our goal for this patient was to improve his ventilation and his oxygenation. My patient is a 45-year-old male who went into cardiac arrest respiratory failure. He presented initially in the ER with a fever and a productive cough that had begun 1 day prior to his ER visit. His initial vitals was a heart rate of 86, a blood pressure of 130/87, a respiratory rate of 15, a saturation of 97% on a 2-liter nasal cannula, and his chest x-ray showed a right middle lobe infiltrate. And then his initial ABG was a pH of 7.32, a CO2 of 37, a O2 of 78, and a bicarb of 24. After being admitted, we went back to reassess the patient, and his heart rate had gotten higher. It was a 120. His blood pressure was 85/60. His saturation was 78% on a non-rebreather mask. And in my patient assessment, I noticed that the patient was obviously using his accessory muscles. He was less responsive, diuretic, and there were bilateral crackles in his lungs. His chest x-ray showed bilateral diffuse lung capacities, and his next ABG showed a pH of 7.17, a CO2 of 55, an O2 of 58, and a bicarb of 24. So at this point, we decided that intubation and mechanical ventilation was the best option for this patient. Okay, so I'm pre-oxygenating this patient. We're going to be doing his intubation procedure. He's 80 kilograms, so we're going to have a 7.5, an 8, and an 8.5 size ET tube ready. I have Shelby assisting me, and we're going to go ahead and begin the intubation procedure. So I've pre-oxygenated the patient, and I'm going to get the scope from Shelby so that I can visualize the cords. And then the ET tube, this is an 8 with the stylet. I'm going to make sure it's at 24 at the mouth so that it is the right depth for this size ET tube. And then I'm going to check for chest rise and use a CO2 detector to make sure that we are in the right spot. So we have chest rise and we have an positive CO2. So we're going to go ahead and inflate the cuff now. I'm going to have Shelby do that while I continue to bag the patient. Shelby take over bagging while I test the cuff to, actually I'm going to secure the tube first and make sure it's not going to go anywhere on it. Alright, now I'm going to use the pressure manometer to check the cuff to make sure that the pressure isn't too high so it doesn't cause any tracheal damage, and make sure it is between the 20 and 30 centimeters water pressure. Okay, so now that my patient has been intubated, we are putting him on a mechanical ventilator. So I'm using the Puritan Bennett 980 ventilator, and this ventilator, after running the SST, I'm going in to do a new patient and to set my parameters, which I've already done just to show you again. I'm going to go here. I have my frequency set at 12, my tidal volume set at 500 because his idle body weight was 80 kilograms, so we have a range of 400 to 640 milliliters, and we have it set at 500. We have a flow of 42 liters per minute based on his respiratory rate and his I time, which his respiratory rate is 12 and his I time is 120. His FiO2 is at 100%, and we have a PEEP of 5 set. So then I'm going to close that and go into my alarms. So in my alarm panel, the first thing I'm going to do is set all my normal alarms. So for the peak, I'm going to do that as 10 above, so it's at 26. We're going to make this 36. And then for the frequency, I put that at 30. And for the minute relation, we did 4 above and 2 below, so it's currently at 5.3. We put the high alarm at 9.5 and the low alarm at 3.2. And then for the tidal volume, he's currently getting 445 milliliters. So we put the high alarm at 540 and the low alarm at 345. And we're going to accept that. But first, we're going to put the apnea alarms. So where the time on the apnea alarm, I put that as low as it'll go, which is at 6 seconds, so that they miss very minimal amount of breaths. And then the frequency and tidal volume and flow are all the same. It's 12 breaths per minute, the 500 milliliter tidal volume, and 42 liters per minute for the flow. And our FiO2 is, of course, 100% on an apnea setting, which our patient is already receiving 100%. And we're going to accept those. And that is it for setting up the patient on the ventilator. 30 minutes after they were put on the ventilator, we did another ABG, and we got a pH of 7.2, a CO2 of 60, a O2 of 50, and a bicarb of 26. So we are going to increase the minute ventilation to help blow off some of that CO2 because he's still acidotic. So we're going to increase the respiratory rate for this patient. So we're going to increase that to 15 just to help blow off some of that CO2. And so now I'm going to go back into my apnea alarm and increase that frequency as well, just to keep everything consistent. Okay, so my patient has been on the mechanical ventilator and they are coming back with a normal ABG and showing signs of spontaneous breaths. So we're going to put them into a spontaneous breathing trial to make sure they are ready to be taken off the ventilator. So we have switched them to an SIMV mode on this ventilator. And we put their pressure support at 15, which is going to be used to augment a spontaneous tidal volume. And we're going to decrease that pressure support in 3 to 6 increments, so 3 to 6 centimeters of water pressure in those increments until it gets to 5. And this is going to be used to augment a spontaneous tidal volume, and when that spontaneous tidal volume gets to 10 to 15 milliliters per kilogram, or we have a spontaneous frequency of 25 breaths per minute, the patient is ready to be taken off the ventilator. We're going to be sure to assess the patient's RISC score and have it at less than 100, their NIF at greater than -20, the tidal volume, vital capacity, and the ventilation to ensure that they are ready to be extubated. Okay, so my patient was successfully extubated, and now we have them on a nasal cannula at 5 liters per minute.